Assalamualaikum and very good morning, everyone. It's my pleasure today to introduce our dear Dr. Atiqah binti Abdul Rahman, a medical lecturer and family medicine specialist at the Department of Primary Care Medicine, Faculty of Medicine, University Malaya. She advocates for patient-centered care and the mental health of healthcare workers, including doctors and academics. She established the Wellbeing and Mental Health Committee in our department. She earned her MBBS from Barts and the London School of Medicine and Dentistry, Queen's Mary University of London. She completed her foundation years in UK and later became a member of Royal College of GP through the Barnett Vocational Training Program. Today, it's my pleasure. She will share the insight into the well-being and mental health of medical professionals, including academics. Please join me in welcoming Dr. Dalila.
Thank you, Fadzilah, for that kind introduction. I'm just going to share my screen now. Thank you. So the reason why I've chosen this topic is actually because when I started here, I was talking to some of my colleagues, and then I realized that actually a lot of them are struggling mentally, emotionally, psychologically, and I felt like something needs to be done about it because it so far it seems like we are only discovering these things after things have gone wrong. For example, if there has been a patient incident or if they failed their exams, by which point it is already quite severe. So my aim is actually to have a more proactive approach to prevent it from, getting to that stage. But before I start, I'm just going to talk about Prof. Steve Robson. So he is a professor of Ops and Gynae at the Australian National University Medical School. He's currently the president of the AMA, and he was previously the president of the Royal Australian and New Zealand College of Ops and Gynae. So when you look at him this way, he sounds like a very successful, very powerful person, even invincible perhaps, but you can never guess that he actually had quite a dark background, and he's written this sort of like a memoir that was published in the Every Doctor book. So as an intern, he tried to kill himself. He has kept the entire episode to himself, and he's only, spoken about this openly now, and this happened about 30 odd years ago. He used to find med school very difficult. He didn't find that he was a natural academic like so many of his peers. He was working a long way from his family. He just felt overwhelmed with inadequacy. He had a patient die and felt responsible for it. His seniors weren't exactly glowing in their feedback. And he felt like all of his years in medical school was a complete waste, and he was, little short of dangerous. So all of that essentially listed down the dark side of medicine. Now, medicine can be an amazing career, and personally, I think it's a huge privilege to be able to serve others, making people's lives better with our knowledge and skills. But it's also, highly competitive. You're surrounded by very intelligent people, and sometimes you feel like you're not good enough. You're exposed to lots of misery, trauma, and you can have what we call vicarious trauma. So symptoms from repeated exposure to trauma, similar to as if you experienced it yourself firsthand. So you also get a lot of isolation as well especially during training. So you're being pushed and thrown to random hospitals, sometimes in rural areas and far away from your family, with long hours, heavy workload. Sometimes you get seniors who are toxic and bullying. So it doesn't even, I haven't even touched, patient issues, so difficult patients, angry patient, and God forbid if something goes wrong and you're involved in a significant incident, investigation, then that can definitely put a major toll on your mental health. And actually, a major study in the UK has shown that doctors who were referred to the General Medical Council, that's the Malaysian equivalent, sorry, the UK equivalent of the MMC, they're twice as likely to have self-harm and suicidal thoughts. So all of this, it leads to very high mental health and suicide rates. So why don't doctors seek help? So based on what Prof. Rodson has written on his memoir, at the time he only knew one psychiatrist and he was about to become his intern, so that would be very awkward. He said he was worried that he was never going to be able to buy income protection or life insurance. And he was worried that if anyone found out that he was on antidepressant, that he could get in trouble with the medical board. He was also bonded with the Australian Navy, so he was worried that if he was rejected, he had to pay back all of his return of service, and he knew he couldn't afford it. So all of this, it basically gives him an idea that, seeking help is a sign of weakness. And it's something that, you should be ashamed of, like something's wrong with you. So he's chosen to hide it. So when I was speaking to my colleagues as well, it's the same kind of barriers. They're worried that if they spoke to one of their seniors, the news will spread and the whole department would find out. And sometimes we do talk about people with the greatest intention, the nicest intention, to help them, but sometimes it is counterproductive, especially because of confidentiality issues. And they're worried that, if people found out that they have, say, depression or anxiety, people are going to think they're not fit to practice and will treat them differently, or probably, put them under more scrutiny, more supervision, and they don't want that, obviously. And also a huge part of barrier is stigma. So this is stigma from the external and also internal. So, stigma towards yourself, feeling like, what's wrong with me? Something's wrong with me, and it's something that should be hidden. So when we talk about mental health in doctors are a very specific population of patients with their own special risks. So essentially, they have good access to medication, so they tend to self-treat, or they get their friends to prescribe for them and provide ad hoc medication without proper follow-up, which is obviously not the right way of doing it. In a way, doctors are the worst kind of patients, because we tell patients one thing and we do a different thing. And also, there's this issue with presenteeism. Now, I remember when I was a junior doctor, I had a senior who came with his ankle in a boot because he's had a fracture, and he didn't take any sick leave. And he said, quite proudly, I've never taken sick leave in 7 years, so I'm not going to start today. And it kind of gives, he was wearing it as a badge of honor, but it gives the wrong impression that, taking sick leave, taking care of yourself is a sign of weakness. Now, because they have access to this medication, they will tend to mask any mild symptoms, like insomnia, for example, and they tend to present very late, when things are quite severe, and worst case scenario, we never ever found out about, the fact that they're struggling until they're gone. So that's the sad reality. So Prof. Robson, going back to him, made careful plans to kill himself. He wanted the end to be painless and clean, so he stole some supplies from the ward, and he started writing letters. So incredibly, a work colleague arrived unexpectedly and began knocking on the door, wouldn't leave because they saw that the car was parked outside, so they know that he was inside. So at that point, he had already inserted a cannula. So he took it back out, to go and speak to this friend, and he spent quite a while talking to the person, and he felt like that was the thing that saved his life. Now, just talking about burnout, it is incredibly prevalent. If you look at different literatures, they will report different rates, but it can be up to half or even more than that, in terms of the doctor population. And depression and anxiety, it's about 30 to 40%, and it's higher post-COVID. And it's similar in Malaysia. So there's been lots of studies in Malaysia, and they report around 30% prevalence, but I think that is probably majorly underreported. Now I'm just gonna touch a little bit about protecting your mental health. So the way I'm gonna talk about it is what we can do as individuals, what we can do with others, and also what the system can do. Because it's all very well talking about what the individual can do, but they can only do it up to a certain point. So it has to be a multi-pronged approach. But in terms of protecting your own mental health, building your own shield, it's mindfulness has been shown many times. So there's lots of evidence behind it that it can actually improve your mental health and well-being. There's also lots of evidence showing that certain coping strategies are better than others. So, for example, if you adopt a problem-solving approach or emotion-focused approach, it's better than dysfunctional coping mechanisms like avoidance or denial, things like that. So I'm not going to say infantilize doctors by talking about you need to eat well and exercise. I think we all know that. So I'm just going to swiftly move on to the next part, which is supporting your colleagues. This is something that we can also do regardless of our seniority. Just creating a very safe haven for people to talk about their mental health. When you bump into your colleague in the corridor and you ask them, how are you? Really, actually ask them and really listening and showing them that you're interested, because a lot of the time we will just say we're fine, but then are you really fine? And then just trying to listen rather than give advice, and also build relationship by sharing your own struggles. So the relationship should go both ways. Something about stigma. So I think the way we talk about mental health, especially about our patients with mental health condition, it really matters. So sometimes we would use certain mental health conditions as a slur to describe bad behavior. Obviously, that's unhelpful both for the patients and for the culture. Now, Prof. Robson has kindly shown us the deeper, so the darker side of his history because of stigma. So he wanted to end the stigma. So he wanted to normalize conversation about mental health and essentially giving people hope. People who are struggling, that actually you can get through this and you can actually end up becoming very successful like himself. Now, the systemic practices is, if anything, I think it's the most important thing, because you can have the most healthy, the most resilient doctor. You put them under very harsh condition, everyone will eventually break. So it's important to make sure that the environment around them is conducive for the mental health. So things like manageable workload, adequate rest, and then access to free, confidential services. So we do have practitioner health PPUM. So I'm just going to pause here and acknowledge the fact that, you know, some of the things I say in this presentation can be quite triggering and quite heavy. And if you find that you're affected, then please speak to someone, you know, someone trusted. And if it's, you know, in PPUM, then we do have a confidential service for staff members, and they're really good. And then the other thing is peer support services. So things like mentoring, well-being champion. And I'm going to talk more about, you know, what we're doing in our primary care department. Just a quick, so I want to say rant, but a quick part on mandatory health declaration. So lots of countries, including Malaysia, are still practicing this widely. So essentially when a doctor is trying to register to, I don't know, MMC or applying for a new job, they have to declare you know, whether or not they have mental health problems. And I know this practice came from wanting to protect patients. But actually, what it does is it just perpetuates mental health stigma by linking psychiatric condition to performance impairment. And actually, if you search literature, there's actually nothing, there's no evidence showing that asking doctors whether or not they have mental health problems actually improves patient safety or helps you to identify unsafe doctors. But what it does is actually it leads to delayed help seeking. So doctors just tend not to seek help because they don't want to have that diagnosis, you know, in their medical record. And sometimes they just don't report it. And obviously, you know, apart from the stigma, it's also bad for the doctor and bad for the patient. So you can see how this practice is actually counterproductive. Now, the US Federation of State Medical Boards has provided recommendations for mental health related disclosure. So they've mentioned that you should only ask about any condition that causes current impairment. Rather than asking a broad, you know, have you ever been diagnosed with a mental health condition? And providing a safe haven for reporting options. So basically, if giving the doctors option not to report it, if, their mental health condition, as long as they see a mental health professional, and promoting the use of supportive language rather than punitive language. Now, just a quick blurb on what we're doing in the Department of Primary Care Medicine. So essentially, I've you know, collected like-minded people who also find you know, that you know, mental health and well-being should be something that at the forefront of our mind rather than an afterthought. So this is our team. So there's Prof. Fadzilah, our moderator, and also the head of department. And then we have Prof. Sajal, who is our mentor and also the advisor. She has been the pivotal inspiration with all of this. And then that's me as the lead, Dr. Khalid, Dr. Yor. Dr. Zafir is our MO rep. So he essentially collects the opinions from our MOs so that it doesn't become like a top-down kind of thing. Yeah, and we also have Dr. Rashida and Dr. Dasilan to help him, and Dr. Angwele as the PG liaison. So this is our objective. Essentially, it's just to promote a safe environment for their mental health and to enable early identification to reduce some of the barriers to seek help, to have a very clear pathway and to just monitor what we're doing, making sure that our interventions are useful. So I've sort of simplified it into 4 pillars. So the individual tools, the training. So the mental health first aid training is actually training on how you respond to others who are in and mental health distress, because how you respond really matters, because if you respond wrongly, it might make things worse. So we're trying to get people to be trained in this. And obviously, we want to make sure that the environment that our MOs are working in are suitable or conducive for their mental health, and we want to make sure that they are given enough opportunities to network and be supported by both their seniors and also their peers. So what we've done is we have started a actually it's a 2 weekly, not weekly mindfulness session. And we've done 2 sessions so far. And it's a very short session with just a brief formal practice on mindfulness. And then afterwards, from 8:45, just before clinics, we've done sort of like a drop-in session for any of the trainees who are struggling with anything to just come forward and talk to us in a confidential manner. So this is the standard mental health first aid code that I was talking about. Now, the optimal working environment. So what we did is we've basically done a couple of, I would say, town hall sessions just to collect the kind of things that they're struggling with. Obviously, lots of things we couldn't really solve, but if it's related to their training, then we can forward the concerns to the postgraduate team. For example, if it's regarding clinic, then we would just summarize the issues and then forward it towards the clinic team and see what they can do to help. We've also started a peer support session for the year 1 family medicine trainees. So essentially these are just, you're just sitting in a circle and then you talk about something that's been bothering you recently. And it's normally, with a recent difficult encounter, so that they don't just keep it inside and ruminate on it and start to blame themselves, for example. So the whole idea is that it provides a confidential, safe space for your peers to listen and to reflect and to understand the situation, both on the patient's perspective and in your own perspective. And personally, when I was training, I used to do this every week, and I always found it very helpful because you don't tend to bring things home and keep you awake at night. So in terms of our future plans, hopefully we can translate some of this into research. I was planning on doing sort of like a policy on, confidentiality policy, for example, for the staff members. And we were also planning on incorporating this into the PG training, so the family medicine specialist training. And actually they've already incorporated a couple of sessions on mindfulness in their formal teaching session. So I think that's great. I think, if we can build this for our doctors in the primary care department, what's stopping you from doing it in your own department? And I hope it would be sort of like a catalyst for every department to adopt this, to have a formal pathway on protecting the mental health and wellness of your staff members. If you do like to, ask more questions, collaborate, please contact me. I should put my email, but it's dalila.abdurrahman@um.edu.my. All right. Thanks for listening. Stop sharing now.
Thank you, Dr. Dalila, for your wonderful presentation, as well as sharing what you have been doing in our department in helping especially the postgraduate trainees and also the academics. There are a few questions in the chat box. I will read it out for you. First one is from Prof. David Oregon. Do you have any idea of the incidence of burnout in our organization?
I don't think there's any study, a cross-sectional study or anything like that. So it's all anecdotal, unfortunately, just based on my own personal experience. but it's high. And there's a lot. So when I was doing the town hall session, I asked a show of hands, anyone who's had a mental health issue or a burnout, and it was the majority, almost all of them raised their hand.
I think there's no specific studies done in our
Yeah.
organization. Perhaps somebody can start doing it. Okay. So there's another question from him also. Are you familiar with Carter Labourer's work?
No, I'm not familiar with him, but now I'm gonna go and look him up afterwards.
Okay, so there's one more question in the Q&A chat box. Do you think the senior academics find it more difficult to cope with this kind of mental health stress as a teenager in terms of support person? From Prof. Waiki Chan.
Sorry, what was the second part? Is what?
I'll read out again. Do you think the senior academics find it more difficult to cope with this kind of mental health stress as teenager in terms of support person?
Ah, so again, there's no study on mental health problems specifically in our population, but the incidence of burnout, mental health problems are significantly higher in more junior population. So starting, in your career, um, but that doesn't necessarily mean that burnout isn't or mental health problems isn't prevalent in more senior doctors or academician. Obviously, the stress factors are different. Um, and senior physicians have higher responsibility. They would have to have more accountability, so the stress comes in that sense. And yes, they definitely have less in terms of senior support because they're the senior person, and obviously they have their colleagues and things. So I I think it's less prevalent than more senior, more junior, but it is still a huge issue.
Okay, let's move on to our next question. I think this question is in regards to undergraduates. Is there anything we can do at undergraduate level to improve mental health issue among our medical student or trainees?
Yeah, so definitely there's lots of things that we can do. And it's similar to to my presentation, the kind of things that we can do, obviously more tailored to the medical student population. So they're, preclinical, some of them. Uh, so my interventions are focused more on the postgraduate trainees, but I can't see, why we can't translate some of them. Um, we definitely need to have a clear workflow on what to do if a trainee comes to us. In distress, and definitely shouldn't be something that is reactive. So it should be a proactive approach. So, not waiting until they fail their exams before doing something. We have to have a way for us to be able to pick up these struggling students before things become really severe. But yeah, definitely lots of things can be done.
Thank you. There's one more question from Muhammad Almi bin Muhammad Yasin. Any role of public health physician in this program?
I think everyone has a role, not just public health physicians. So if you're talking about your own department, the public health department, then, definitely it's something that can be done where you can, have a committee who support each other, each other's mental health. Now, my interest is specific to doctors and healthcare professionals, and I think the approach is very different compared to the general population, because the most doctors have quite high literacy so they have the knowledge. So there's not much point in terms of psychoeducation, teaching them what is mental health problem. They kind of know all of that already. Most of it is about, reducing the barriers, and giving them the support and the safety to seek help. Yeah.
I do agree with you, Dalila. I think creating a supportive environment is important in every phase of life as a healthcare professional. Just want to ask you for one advice. What advice would you give to our young healthcare workers that plan to enter this profession? I'm sure there are a lot of medical students listening to this. So maybe you want to give one or two advice.
Oh gosh. I always find it very difficult to give advice because I don't think I'm qualified. But I think it's important to recognize that, if you're struggling with something, you're not alone. Lots of people struggle with it. They just hide it very well. And you're probably hiding it very well as well. So, just recognizing that you're not alone and talking to someone about it. And I know you might be scared to talk about it, but you know, if you're a medical student, there's not much that you can do to change the system. But finding a senior that you can trust, for example, or a mentor, or even a more senior medical student, that would really help in your journey.
Yeah, thank you, Dr. Dalila. I think it's time's up today. As we close today's session, let us remember that those who care for others are also deserve to be cared, compassion, and understand. A strong healthcare system is built not only on clinical excellence, but also on the well-being of the people who serve within it. I believe that changing the culture of healthcare starts with a small but meaningful action, checking in on ourselves, supporting our colleagues, and normalizing conversation of mental health. May today's discussion remind us that seeking help, I think that's what Dr. Dalila is emphasizing throughout her talk, is not a weakness. It is a courage, and by healing the healers, we strengthen the care we give to our patients and communities. Thank you, Dr. Dalila, for your presentation and everyone for being part of this important discussion.
Thank you.